Hello, and thank you everyone for joining us for today's webinar. I'd like to recognize Becker's Healthcare for this webinar and also our sponsor, Convatec, for taking the time to produce this content. Today's webinar is going to be on optimizing outcomes in same-day arthroplasty, and we're extremely excited to be joined by two very well-accomplished surgeons in arthroplasty and in particular in same-day arthroplasty. Dr. William Long, orthopedic surgeon at NYU Langone Health, and Dr. Lee Rubin, orthopedic surgeon at Yale Medicine. As I mentioned, both have extensive experience in this area. Each of us are going to give 3 separate talks on a specific topic, and then we'll spend a few minutes afterwards doing a question and answer session. Our first speaker today is going to be Dr. Will Long from NYU, and he is going to be talking about outpatient arthroplasty. Dr. Long, I'll turn things over to you.
Thanks very much, Brian. And thanks everyone at Convatec and Becker's as well. So I'm going to start off discussing outpatient selection and execution in total joint arthroplasty. This is going to reflect a lot of our NYU Langone experience. We're now up to about 1,500 total joints done as an outpatient, or as we call them, same-day discharge. I think this has been a swell of care in this area post-COVID. So I think this is sort of a hot topic now. My disclosure, I think an outpatient total joint replacement is a fantastic procedure, and I'd have my total joint performed as an outpatient if I could. This is my father. He's 83 next week. He had his knee done 6 years ago by Dave Backstein, a friend up in Toronto. This is a 1.5 mile hill we're going up. He was home the next day. Unfortunately, they wouldn't let him leave at the age of 77. He was rounding post-op day 4, operating post-op day 7. So very successful, rapid recovery program. And we actually biked 50 kilometers that day, so over 30 miles. Why would I perform an outpatient total joint? There are a lot of interesting aspects. I would put marketing, although it's first on this slide, down towards the bottom. I think patient expectations are really important. Short length of stay, so that's important for the hospital and the finances. Less complications, reducing readmissions, and lower cost. So if we drill down into the economics, there are 3 possible venues we can perform these. Charge total joint is 50% more profitable for us. Even in our Medicare total joints, at least initially, we could have a long discussion about how that's changing. And if we're able to translate our hospital experience, where we've done the majority of our total joints, into an outpatient surgical center or an ASC, we'd even be more profitable. When you start thinking about coming into this field, I think you really do need to sit down and have an institutional leader. I would suggest a surgeon champion. There's a lot more planning that goes into a same-day discharge total joint replacement, and I think we need to document and reflect that. Otherwise, we're at risk for further degradation of the RVU-based incentivization and payment program. And anyone who's read the recent notes from AAOS and the AAOS is familiar with those concerns. So communication, we have digital platforms, we have cell phone access to the surgeons and the surgical team, and someone has to 24 hours. Here's where we start with our human investment. So patient investment. We insisted when we started off that patients have a personal coach that comes to their preoperative session, that's present on the day of surgery, and that actually stays with them overnight the first night. So we do ask that of the patient and their caregiver. From an institutional standpoint, they have a one-on-one clinical care encounter, and I get a big report from this. They do a 2-hour physical therapy and occupational therapy consult pre-op, and they have care extenders that are educated, and the whole team is organized to perform these in a functional fashion without significant concerns, hopefully. So in our initial practice, we were somewhat conservative. We had a number of criteria that they had to meet to be eligible for the outpatient designation. And we had a number of exclusions. You can see those here. I would suggest some of these might exclude you from a total joint, but anyway, these were our exclusions for the outpatient system. We look back at them. Joe Bosco took a look at this with one of the residents, and remarkably, and certainly to me, he found that 70% of all of our patients done with the 2015 to 2016 timeframe were actually eligible for outpatient status. When they looked at the reasons why they weren't candidates, BMI of 40 was the biggest issue. So we do a lot of bigger patients at our center. Severity of comorbidities, sleep apnea, stents. You could argue their heart might work a little better after a stent, but certainly that's a risk or a concern. MIs and ASA class 4 and a number of other issues. So I always think about it as starting in the preoperative framework. So you want preparation, mental, both for the patient, I would suggest for the surgeon and for the caregiver. And if you don't involve the caregivers in this step, they can really scupper the whole system. From a medical standpoint, we're very proactive. The scripts are sent in advance. Assistive devices arrive at the house before you come to the hospital. We set them up with a mobile app, and the home care staffing and PT are already organized. So I actually get an email a week ahead that shows what their discharge medications are and where to send them. As far as the operative setup goes, we're very comprehensive about the preoperative analgesia, short-acting spinals, and they are very short-acting, so you have to be consistent as a surgeon. Reducing our narcotics, a steroid dose is very effective as pain control. Comprehensive periarticular injections. For our knees, we do saphenous nerve blocks for everyone. Tranexamic acid is used for everyone. This will be my one push for Convatec, but we use an Aquacel impervious dressing for all of them. I find that really, really helpful in terms of preventing the unnecessary calls, touches, pokes, and concerns associated with a normal healing wound. Timely surgical execution is something that cannot be overlooked. So my part as a surgeon, the PAs, the assistants, the scrub techs, you can't go into a room with someone who's never done this before and effectively do it in a timely fashion with the expectation that that patient will be up an hour and a half later and leaving the institution an hour or even half an hour in some cases after that. So post-op, they're up very early with physical therapy. We have good fluid management. I'll show you why that can be a concern. The patients must void before they leave. The team has to be on the same page. Initially, I did phone rounds, and this was really for my own education. I was a little concerned on how they would do, so I called everyone the next morning. I think it was a really nice introduction for me as a surgeon to this new paradigm. Now I'll let my PA or the nursing team do it. They send me a very comprehensive questionnaire on how the patient's doing post-op day one. Interestingly, we have not seen the oft-mentioned issue related to more calls in the office, and I think that that comes back to the significant amount of increased preoperative preparation that goes into these cases. So when we look back, and again, this isn't up to date in 2020, but I wanted to show where we started. We started predominantly with total hips. We moved a lot more into total knees over the last year and a half. We had really looked at our failure to launch. So our failure to launch meant they didn't go home the same day. So 93% of our early cases, we're now up to 96 to 97% go home the same day. And we look closely at why they didn't go. So the reasons for the failure to launch. That could come down to some surgical issues, but that one's a tough one. That may occur in some cases, some unexpected issues, some increased osteophytes around the joint can often lead to that, a little more difficult exposure, and sometimes just the idiosyncrasies of the surgical field. Sedation, hypotension, late cases, and some of these other issues. And what we then did was we took a closer look at what was modifiable. So if you look at 80% of our early failures to discharge would be what I would consider modifiable. So sedation, we really had to discuss this with some of our anesthesiologists who prior to this had been very comfortable giving a medication to allow the patient to comfortably wake up over hours and hours. Hypotension was an issue. So we actually piloted a study giving them fluid resuscitation the morning of surgery. Late cases, so we tried to put them a fairly easy solution. And comorbidities and caution, well, that's really surgical experience, I would suggest. Our readmissions, so our ED visit and readmission rate remain below 1%. We had 4 ER visits. You can see one gentleman actually passed out on post-op day 1 while smoking a cigar and attempting a bowel movement, but most of these issues were not significant. Our readmissions, unfortunately, there are surgery through infection. One had a periprosthetic fracture. I would argue that these would not have been significantly mitigated by an extra day in hospital. We really embrace this enabling technology, and I was a little slow on this, but I've really become a champion. I think this is very effective for patients. Even elderly patients become very engaged. So we published on this. Roy Davidovich was a champion of this, and you can see with the electronic patient rehab versus home health services in our total hip patients, it's a significant cost savings without any significant reduction in outcomes. When we examined it with respect to how engaged patients were, we found the younger patients, and the more you clicked on it, the better you did with your patient-related outcome scores. And perhaps we still needed to partner this with some home health aids in the total knee replacements scenario. Are there any other benefits? Well, we looked at this. We didn't see any difference in our outcomes at 6 weeks. And Roy again looked back with one of our research fellows and didn't find any difference in the deltas. We did see a significant increase in the HCAP scores. What we found was the less time you spent in the hospital, the more you liked it overall. So they might like you better, and that does have some future implications for remuneration. And again, we increased our profit significantly. As a result of this experience over the last 2 years, I've been routinely doing 4 to 5 total joints on 1 to 2 Fridays per month at a surgery center. And I am a minority owner, full disclosure, in Long Island. It's a beautiful, new, big, spacious, state-of-the-art surgery center. And I have not had anyone stay overnight or be transferred to the hospital. So again, and I have removed some of the early precautions that I had, and I'd be happy to discuss those either in the discussion portion or later offline as to which ones I've had to hold on to and change. I don't think these protocols are for everyone, but what I would suggest is as you embark on these programs, what you realize is that these techniques are really helpful for everyone. So here's a 92-year-old retired president of the hospital board. He wouldn't let me do his hip replacement until I agreed to him that he could go back to downhill skiing, which he did a few months later. And rather than coming in for a 1-year follow-up, he sent me a postcard from Altus. So, you know, very effective, and I think really benefited from the reduction in narcotics, the early mobilization, you know, the old-fashioned confusion that used to develop. So perhaps it's how you spend the first night, not where you spend the first night, that's important. I do want to touch on one other issue that's come to the forefront recently, and that is the Medicare outpatient designation. I want to point out that in this first slide, these are not outpatients, rather these are same-day discharge. We did a very, very select small group of Medicare patients with outpatient total joints, and they did very well. We did not see significant differences, but I would suggest to you this is a very select group. There is a term that Medicare uses, which is outpatient, which refers to actually less than 2 midnight stay in hospital. We recently looked at this and have submitted it for publication. Our total knees that can be sent home in less than 2 days tend to be younger, male, healthier, with higher preoperative KOOS scores. But despite our very best efforts and some very, very robust protocols and a very large team on the back end trying to get these people home, we were really only able to be successful in 20% of our Medicare patients going home in less than 2 days. So in conclusion, patient issues are critical if you're going to embark on one of these programs. I think patient selection is important. Patient engagement is important. You need institutional buy-in. You need a surgeon champion. You need to examine your early results and some of the barriers and some of the issues you develop as you go on. Start at an inpatient center. I think that's the safest place to do it. Cross the barriers slowly, enable the patients, and I think you can have a very successful program.
All right, how many days out are you from?
This is an example of one of our CFO sons. He came to see me 9 days after surgery, and I'll let him speak for himself.
Anything. All right, hop up. Let's see a walk. All right, come on and go down here. All right, nice and quick down the hall to Lena.
So I'll leave it at that.
All right, come on back.
Thanks very much.
Well, thanks so much. That was great. It's certainly going to generate a lot of discussion, and appreciate you being so comprehensive. I do wonder a little bit, what does it mean when both the president of the hospital board and the CFO of the hospital's son don't want to stay in their own hospital?
Very interesting. Two different hospitals. But I think, it really does speak to the benefits to getting people out. And Brian, I'd be interested in, and I'd bounce this to both of you, Lee as well. I've seen a tremendous increase in patient interest in not being in hospital after COVID. I don't think that this is a short-term issue. I think this is a long-term paradigm shift. So I'm very interested in where we are a year from now.
Yeah, absolutely. I agree, and we'll touch on that in the discussion as well. I think it's here to stay, and I've probably spent more time talking against outpatient arthroplasty more than I did for it, and hearing people like yourself and Lee talk about this, and just the amount of work and the effort that goes into creating this. I've certainly changed my color on this. And, I think the biggest emphasis is that you can't just do what you were doing in the hospital and send patients home the same day, right? That can't be the only change that you make, is say, all right, I'm just going to do this the way I always did it, and you can go home today. I mean, I think you very clearly showed how much work and effort goes into creating a program to be able to do it safely. And I think that was part of my hesitation was the work, but also seeing in the past some people doing what they normally do and try and send people home, and a lot of the burden that it created on our practice. So that was great. It was really comprehensive. So thanks for that. And we'll certainly have more about that in the discussion. So we're gonna shift gears just a little bit here and talk about wound management. And I'm going to give a little bit of a general overview, and then Dr. Rubin's going to dive a little bit deeper into wound management specifically as it relates to the direct anterior approach, and a lot of the work that he has done at his center and some of the data surrounding that. So I'll give a little bit of an overview in that regards. I think just by way of disclosures, I am a paid consultant for Convatec, so please keep that in mind, that I am conflicted as we talk about wound management. And when we look at this in the hospital, and perhaps we're dealing with a different subset of patients in the hospital than the uber select patients that we decide to send home the same day, it's pretty clear that wound complications and wound issues are really the number one reason that patients come back to the emergency room, or even potentially get readmitted. And we all know that problems with the wound can be a direct relationship to ultimately the development of surgical site infection, and particularly in our line of work, periprosthetic joint infection, which is a devastating complication. And again, so you could argue maybe this is a hospital-related complication where it's a different subset of sicker patients, higher risk factors, things along those lines. But in actuality, I went back and dove into literature just over the past year or two, as we've seen this ramp up of outpatient total joints, hips and knees, and lo and behold, it basically mirrors the hospital situation, so that wound-related complications, surgical site-related complications are still by and far the number one driver that patients will go back to the ER, will have to get readmitted to a hospital setting, an acute care hospital, even if they're having their total joint done in an outpatient setting, right? And that can be a very big deal. I know in our center, at our surgery center, the patients don't have an option to stay. They have to be admitted to an acute care hospital. We have a lot of now bundled payments with private insurers. And as you know, those readmissions can really be bundle busters. So we face the same issues in the outpatient setting that we do in the inpatient setting. And I think when it comes to wound management, there's really 4 critical questions that we have to answer. Who is at risk for wound complications? What's the best wound closure method? Controversial and probably not solved. What's the best wound dressing? We have a lot of data on this now. And how do you manage patients that have the persistent wound drainage? I think despite all of us on this webinar, I know have talked about this and we lecture about it, and yet there seems to be still wide variety of how you deal with patients that have persistent wound drainage. So we'll touch about that. So who's at risk? I think it's important, regardless of where your site of service is, that we don't necessarily treat everybody the same, that you have to take an algorithmic approach to wound management and take all the factors into consideration, right? It's not just what their leg looks like, it's also some systemic factors that they may have. And I think also some environmental factors, where those patients are going to and where those patients came from, that do have implications in wound healing and wound management. And we have to be careful about treating all of these patients the same, right? So think about local factors. Prior incisions is probably the biggest area where we see surgeons and patients get into trouble, particularly those patients have had local trauma. You have to think about their skin conditions. And while revision surgery is probably pretty rare in the outpatient setting, it may not be soon. And I think we need to start to think about some of those implications about using prior incisions and things along those lines. So, this is old. I mean, Gil Scuderi's talked about this 20 years ago in this ICL about if you, because of the blood supply to the skin, because of the horizontal nature of the blood supply to the skin, if you have two longitudinal incisions, you always want to use the lateral most one so as not to create a bridge in the middle that could potentially become avascular, and avoid making these very large laterally based skin flaps from using a medial over a lateral incision. And I see people really go to great lengths, amazingly, to try and avoid using a laterally based incision and creating small skin bridges, when in actuality, I think most of us know a total knee can still be done through a medial parapectoral arthrotomy with an incision that even is on the lateral side of the knee. The problem is the skin bridge. We say, oh, well, this is enough of a skin bridge, I'll be fine going midline. But what really defines that safe skin bridge is really all over the board. You can see here, I mean, these articles go way back, but 2.5 centimeters up to 8 centimeters, that's a pretty big variation in safe for a skin bridge. And again, I think I see more people get into trouble by trying to go midline down the middle when you could very easily have utilized this curvilinear incision, and you can see the dusky skin edge there. And ultimately these things end up breaking down very easily. And this is a horrible thing to see in the hospital or in your office when it comes back in and you see an avascular skin bridge in between. So what's the best method for closure? I think this is an unsolved issue. This came up recently at the International Consensus meeting. And the question was, does the type of wound closure, both technique and material, affect the incidence of subsequent PJI or surgical site infection? And you can see here that there was a lack of strong evidence that clearly demonstrated the superiority of any wound closure method over the other. I think we all believe what we believe. And I think there is data to support whether you use staples, external sutures, whether or not you run a subcuticular suture and use Dermabond. I think we all feel very strongly about it. But fact of the matter is we probably just don't have large enough and big enough prospective randomized studies to be able to answer the questions. And we all feel anecdotally pretty strong about what we do. This was a study that's now been published, but it was out of Mayo from a few years back, that just simply looked at the tissue perfusion to the skin and using a laser afterwards, where they could look at the skin flow. They could look at the blood flow to the skin edges afterwards when it was closed with either staples or running subcuticular suture or vertical mattress nylon sutures. And you can see that they showed significantly better perfusion and less perfusion impairment with a running 3.0 subcuticular closure. That's what I do. Obviously, I'm pulling out data to support what I do, but I thought it was an interesting study. But I think in reality, if we can't answer the question of what's the best method of closure, I would say it's probably not what you close with, it's who you close with, right? And I think we, in my mind, like, for example, I have a PA that's been with me now for 13 years. I also have residents and fellows that are with me. And there's no question there's a difference in some of those wounds when it's a PGY3 closing the wound, or even a fellow, compared to my physician assistant who virtually closes every single wound, at least from the capsule, once we close the capsule out. And I think, you know, it's like bringing in Mariano Rivera at the end of the game, right? It's pretty much going to be over at that point, because these guys and gals do it so well. It's what they do all the time. It's their specialty. Not only do the wounds cosmetically look amazing, but it's just reproducible every single time. So again, I would emphasize that I think having a quote closer is probably just as important as, if not more important than, the type of method that you use. And then what's the best wound dressing to use? In my mind, I think for virtually every standard risk surgical incision, and Lee's going to expand on this a little bit, there's moderate evidence, and I would even argue in with some of the more recent studies, even stronger evidence to support the use of occlusive dressings. This is what we call these quiet wounds, so to speak. I mean, these are 2 weeks out from a knee replacement, where there's, the bandage has come off at 7 to 10 days, that incision stayed underneath of an occlusive dressing, that it wasn't exposed to the outside environment. Everyone didn't feel like they needed to look at the incision, and it has promoted this really kind of quiet, what we call this quiet healing in these patients. And I think that lack of environmental exposure makes a tremendous difference. And so this was looked at again at the International Consensus meeting, what surgical dressing, and there's a lot of different ones out there, associated with a lower risk of SSI and PJI in patients undergoing orthopedic procedures. You can see moderate evidence, but 81% of the delegates agreed that occlusive and/or silver impregnated dressings, such as the Aquacel AG, have been proven to reduce rates of wound complications, SSI and PJI, compared to our standard dressings that we had typically used. And most of the literature really focused on total joints, which is great. So this is our protocol. First dressing, the bandage is put on in the operating room in a sterile environment over top of the wound with the leg slightly flexed, so it molds to the skin very nicely. And unless we have reason to believe otherwise, we don't change that dressing for 7 to 10 days afterwards. And again, just emphasizing that no environmental wound exposure, particularly when they're in the hospital, particularly if they're going from a hospital to a facility, which I know is rare nowadays, but it's not unheard of. Those places, we really need those wounds protected. And we have shown that it reduces pain associated with having to change dressings and pull tape off of the skin. It certainly is less anxiety provoking for the family. It gives you a good output of looking if there's any drainage on the backside. That backside drainage, of course, is protected because of the controlled release of silver, which gives us a great degree of confidence with the antimicrobial properties of silver. And I think we shouldn't forget the convenience of patients being able to shower right away. You would think it's kind of a given. I think we've all been using this for so long, but still, the look on my patient's face in the pre-op discussion and right after surgery, I say, well, you can go ahead and shower and get it wet. They're still so amazingly surprised about that they don't have to wrap their leg in a trash bag and duct tape to be able to get in the shower. And this is some of the data. This was one of the initial studies back about 7 years ago out of the Rothman Institute that looked at this retrospectively, but almost 2,000 patients looking at periprosthetic joint infection as their endpoint, multivariate analysis, really so they could control just specifically for the dressing. And you can see a 76% reduction in their rate of periprosthetic joint infection when they used a occlusive Aquacel dressing compared to their standard dressing. And this has really been now reproduced in multiple other studies. This was one particular study, again, looked at nearly 1,200 patients, same endpoint, PJI afterwards, and you can see a 4 times decrease in the rate of periprosthetic joint infection. And again, that can be difficult to prove because overall our numbers are low, but it's such a devastating complication when it does happen that if we can prevent any of these, it certainly justifies the use. This was our study that we published now 5 or 6 years ago, where we randomized patients. And this is what we used to use on your left here, which is the old island dressings with, the tape and the gauze. And then we randomize patients to either get that dressing or the Aquacel AG surgical dressing. And you can see we had lower incidence of wound problems, blisters, dressing changes, and we also looked at patient satisfaction. And clearly they were much more satisfied with one dressing, ability to shower, no dressing changes made a big difference. So what about some of these high-risk surgical incisions? I think you could certainly argue that these are not cases that you're going to be doing in an ambulatory surgery setting. Nonetheless, I still think it's worth mentioning, how do we manage these? And in particular, what is the role of negative pressure wound therapy? And again, Dr. Rubin's going to expand on this when he talks specifically about the role in direct anterior hips, but this is looking at these more in a risk stratified pattern and trying to identify the high risk patients. And is there any potential benefit for using these in some of the higher risk patients? And the mechanism of actions of these, is really quite impressive. But from a closed incision standpoint, I think we've all seen how revolutionary they've been in open management of wounds with negative pressure wound therapy. When you put it over top of a closed incision, we know it reduces the tension on that incision. Really pretty dramatically and impressively helps, I think, with the tissue and the tissue edema around those wound edges and the skin, and helps remove any exudate that would potentially build up. Provides an airtight seal, so you get that, again, much like an occlusive dressing, that lack of environmental exposure. I won't go over any of these in detail, but it's been looked at pretty extensively through systematic reviews, meta-analysis, and some large-scale studies looking at it in higher risk wounds, showing that it does decrease wound drainage, helps to seal the wound, and ultimately can decrease risk of surgical site infection. So this question again was posed at the International Consensus meeting. What's the role for vacuum-assisted incisional wound vac? You can see moderate level of evidence that a prophylactic vac appears to be a reasonable option. Again, these are in what I would deem high-risk patients. So for me, that's sometimes the tremendously obese patient, the prior incisions, the revisions where we're making big, long incisions, long surgeries, where they potentially get some third spacing and edema in their leg. Not necessarily routine use in every wound. I think we've really shown the benefits of an occlusive dressing in that setting. But there are some challenges with negative pressure wound therapy. Cost is one of them. Still trying to get them approved from an insurance perspective. If you ever try and get one of these in the office, for us, it's a nightmare. By the time they need it, either the patient's gotten an infection or they've healed it, and it can be really challenging. Putting it on in the hospital isn't that much of an issue, but you still do face some of the cost issues, availability on the hospital ward in the office, and then sometimes the issues with the battery life, depending on how long you want to use it. So historically, this is when I've used it the most. Patients at high risk for drainage post-operatively, as I mentioned, obese, large incisions, revisions. We put it on in the OR over top of the closed wound, historically a 7-day battery life, and change the occlusive dressing. But this was back before they were specifically made to go over top of incisions, things along those lines. And this is what you kind of wheeled them out with. It was this kind of patchwork of the old circular oval vac sponge that you had to cut and make it fit to the wound. And they're, much more streamlined now with these types. And in particular, the Convatec Avel system, this is a canisterless design, really specifically made for closed incisions. It's very portable. It incorporates all the benefits of the hydrofiber that we're all familiar with in the Aquacel dressing. It's disposable, it's small, it doesn't make any noise. And one of the benefits is it has a 30-day lifetime disposable pump, so lasting much longer than some of the other ones that are out on the market. And this is just a picture of the compactness of the system, and it's very, very simple to use. And again, you'll be familiar with the dressing down here at the bottom, very familiar with the adhesive border, and then also the hydrofiber technology. So lastly, how do you manage the draining wound? I think still, as I mentioned, an area that's still very controversial. Part of the problem is, how do you define prolonged drainage? And the consensus group attempted to do this. And, there was no really validated definition of persistent wound drainage. that they could find in the literature. So the consensus from the group that was working on this basically defined persistent wound drainage as any continuous fluid extrusion that occurred really beyond 72 hours from the index surgery. So I think we all agree, if we have a patient that's in the hospital or a patient that goes home and you get the phone call that they're draining and they've continued to drain, for 3, 4, 5 days after surgery, that's very much a concern. The question then becomes, how do you deal with it? Because wounds that continue to drain from multiple studies have shown higher risk of development of surgical site infection, higher risk of periprosthetic joint infection, and persistent drainage really beyond 5 days is probably unlikely to stop spontaneously if it's continuing. There's something underneath it there that's creating that drainage, and ultimately that persistence of drainage is going to lead to a periprosthetic joint infection. And so this is a study that was out of the group in Philadelphia that looked at, if you were able to get to a patient early that had some persistent wound drainage and you could put negative pressure wound therapy on there, of course, in the absence of that patient, any concerns for infection, then they had success in being able to seal the wound over 79% of the time in 122 patients, obviously optimizing their anticoagulation, et cetera. So the key there is in the absence of infection, that you have to make sure that the patient doesn't have infection, optimize their anticoagulation and nutrition. They put these on for generally 3 to 5 days, no antibiotics. And if they continue to have persistent drainage, even with a negative pressure wound drainage, those patients need to go back to the OR to be managed. You can't do this just because it has a 30-day battery life. You can't leave the thing on for 30 days if it's continuing to drain. You need to be aggressive and take these patients back to the operating room. So in conclusion, wound complications are the #1 cause of readmissions. This is true not only for inpatients, but also in the outpatient setting as well. But they don't really have to be if we appropriately risk stratify our patients, optimize the patients ahead of time, and be proactive in our management. So thank you very much for your attention. And I'm going to turn things over to Dr. Rubin from Yale, who's going to give his experience with occlusive dressings, and in particular, the work that they've done as it specifically relates to the direct anterior approach. Lee?
All right, thanks, Brian, very much. Let's see if, the biggest challenge we're having is anticoagulation is one of the big issues that we deal with all these post-op total joints, and really have to be careful about that too. The dressing management is critical, but sometimes the medical service will do us in with their choices and recommendations for very powerful anticoagulation that can promote drainage. So I'm going to talk today about Aquacel dressings for direct anterior approach total hips and talk about some of the data from our center, rationale for why we've chosen some of the dressings and management strategies that we've chosen, a little data review and cost comparison. So greetings to everyone from here in New Haven. This is the Sterling Hall of Medicine, as you see behind me. It's our hub for the medical school. My AAOS disclosures are shown here. So I'm proud to talk about this disclosure with the direct anterior approach to hip reconstruction. Is a book that we published about 4 years ago. That's really a resource for all time for anyone's interested in the technique, and it's really been the Bible for those direct anterior hip surgeons and residents and fellows learning the technique. All the references are there for expeditious surgery. So the direct anterior approach, just very briefly, is an interval between the femoral nerve and the superior gluteal nerve that gets us into the hip joint. It's a nice clean interval. It's intermuscular, it's interneural, so you preserve all the muscles and the nerves to work. And so we do this nice work, and I'll just take you right inside the operating room with me for just a second. Here's an incision in a patient who's supine. The head is to the left, the foot is to the right. This is a right hip. And we get a really nice exposure. I've worked hard to get this exposure for the acetabulum to show you what I'm seeing during the case, the surgeon's view. And we do a nice exposure, a nice hip replacement. This is flipped to the left side, so the head is on the right, the foot is on the left. But we do this really nice surgery. We close up this tissue. We want this to heal. We don't want any problems. We really want to avoid infections. So infections, as Brian's alluded to, is the bane of our existence. The superficial and deep infections are really problematic. And our goal as surgeons is not just to do a nice, clean, beautiful operation for that patient, but to get them to heal. So in total joint surgery, of course, we consider any SSI deep to fascia as a prosthetic joint infection because it's inside the joint and it's exposed to the hardware. The goal is to reduce or eliminate those superficial infections to prevent a deep infection. And this is just a schematic showing that anything deep to fascia in our center is considered a prosthetic joint infection. And we use NISQIP to differentiate. So the Aquacel dressing, in my experience, has been something I've been using dating back to April 2014, which correlates with some of the literature that Brian was talking about. And when I came back to Yale here in 2017, we made this the standard of care for our hip and knee replacement service. And it's really nice. We've helped to eliminate some things that were really unfriendly to patients and to nurses and to residents, like drains. We got rid of those. Dressing changes, we eliminated those. And certainly as we got to the world of outpatient surgery in the last 2 years, as we'll talk about, we've eliminated post-op morning rounds, which really is helpful for everyone involved. So the Aquacel dressing tends to lock in the exudate and trap the bacteria, contours to the wound bed, and responds to the fluid levels by forming this gel layer to contour to the incision. We had to do some nursing education and let everybody know what we were doing and why, because we had to standardize this. We let them know we had dressings that were available depending on the surgeon's preference. We do not want to remove this to inspect the surgical site. We had some pictures here of what strike through is acceptable versus saturation is unacceptable. And we had to be careful with our language about, do we change the dressing? We prefer not to change it to another adhesive dressing. We prefer to use a less adhesive dressing, a gauze or island dressing, if we have to remove it. But it's really quite unusual and rare to have to remove it. So looking at outcomes, as was mentioned, the study that was in the Journal of Arthroplasty in 2014 influenced my practice to choose this dressing, showing the difference with the Aquacel falling the PJI rate from 1.7% to 0.44%. And the subsequent study showed a similar finding with Dr. Geller's patient, single surgeon series retrospective review looking at Aquacel, and the infection rate after switching to that dressing without changing anything else in the single surgeon series was 0.33% versus 1.53% with the standard zero-form gauze dressing that preceded this. There was a really nice meta-analysis that was published in Arthroplasty Today in March 2018, and they looked at a collection of studies and narrowed it down to about 5 studies that looked at the role of hydrofiber dressings. And they found that the standard dressing versus hydrofiber was 4.16% times more likely to have a problem and 2.6 times more likely with absorbent dressings compared to hydrofiber dressings. So these were not specific to silver impregnated, but just the hydrofiber in general. And we believe that that is part of the attraction of this dressing, is that it does work in multiple series. And again, this is a meta-analysis of the most current studies out there. So negative pressure wound therapy involves the application of a controlled negative pressure to the incision. This started, of course, back with deep dressings and has moved now to the closed incisional negative pressure wound therapy, which is what Brian was talking about. And just as, again, an example, we have a few different ones that have come and gone through the institution over the last number of years. We've had the Previne and the Pico. The Avell is a newer system from Convatec that's come out recently to help address some of the other issues with these types of systems. And these go right on the suture or staple line and can last for various lengths of time after the surgery. There is some data that has come out to support the use of these, looking at similar rates of deep infection, but lower rates of superficial infection with negative pressure for total hip at 3.5% versus 1% with the negative pressure. And looking at negative pressure versus island dressings, patients with a BMI over 35 and ASA grade over 3 seem to benefit from negative pressure. So surgeon adoption of these systems really grew, I think, over the past couple of years based on some of these initial series. John Cooper from Columbia has been very active in publishing on what is the role of negative pressure incisional therapies for hip and knee arthroplasty, and has really honed in on the fact that for the high-risk patients, it's really can be potentially very beneficial. And Revision Total Joint Arthroplasty, which was this series, they looked at 108 patients, and they found that the negative pressure had fewer overall wound complications, fewer SSIs, and there's a trend towards a lower superficial wound dehiscence rate, fewer deep infections, fewer reoperations, etc. They looked subsequently on the same type of dressing on periprosthetic fracture patients in the Journal of Arthroplasty later on, injury in 2018. And they found that the patients with negative pressure had fewer wound complications, fewer deep infections, and fewer reoperations related to the surgical site, relative to the standard of care. So we wanted to explore this at our institution, and this was the group led by Vineet Tyagi, who's now a fellow out at Stanford doing arthroplasty. And our group is composed of the following people. This study was published in 2019 in Orthopedics. So we looked at the fact that total hip is more common now, and we wanted to reduce the SSI rate. So there was one surgeon in our institution using negative pressure for all primary hips through the anterior approach, and I was using the Aquacel dressing. So we wanted to compare and contrast these two types of dressings for the same exact surgery. So we thought this was a good opportunity to look at a design where we did a retrospective cohort looking back, and we compared the two groups. We ideally wanted 221 patients in both treatment arms, and we defined the high-risk patients as those with a BMI over 30 and ASA class over 3. So we ended up looking at 275 patients who had their total hips done through direct anterior approach at our institution from 2015 to 2018. And we looked only at primary hips through direct anterior approach. We excluded revision hip arthroplasty, anyone who had follow-up of less than 3 months, conversion of a partial to a total hip, or anyone under age 18. Primary outcome, of course, was focused on SSI, and we recorded a number of secondary outcomes for comparison later on. Demographics were fairly similar across the board. We did see a slight trend towards the BMI being higher in the Previna negative pressure group, but otherwise the rates of these incidences were very similar. It was surprising to us to find that 11.6% of both groups were smoking without us really knowing that, because we tried to screen for that and counsel patients, of course, but we had 13% diabetics in one group and 18% in the other. So this is a fairly good sample of our average patient population. And we looked at the two cohorts. There were 189 patients in the Aquacel group and 86 in the Previna group. The surgical site infection, it was numerically lower but statistically similar. And the readmission rate from surgery, again, and reoperation was quite similar between the groups with no significant differences. When we looked at the subgroup of high-risk patients, again, with a BMI over 30 or ASA class greater than 3, we found that, in fact, the surgical site infections all occurred in this group, as you can see here, the two that we had. And everything else was quite similar between the two groups. So again, we didn't find striking differences in the high-risk group to be using the negative pressure. We looked at the cost effectiveness as another step in this study. At the time we completed the study, the Previna dressing was listed as $486 purchase versus the Aquacel was an acquisition cost of $39, with a delta of $447 between the two. So in the cohort of this study, the difference in price between the two dressings was $122,925, and normalized to cost per 1,000 cases, you're looking at $447,000 of difference without any clinical difference for this cohort of patients having primary hip replacement. And we extrapolated that in our health system. We have 7 hospitals now in the Yale New Haven Health System. And if we do approximately 4,000 cases, you can see the difference really adds up very quickly if everyone got a suction dressing for a routine primary arthroplasty. And I think in this scenario, the cost savings reveals the value that the Aquacel dressing brings to our center. So conclusions of the study that the Previna after direct anterior approach to total hip arthroplasty did not have a statistically significant effect on the SSI rate, and the use of the Previna showed no difference in SSI, readmission, or reoperation in the high-risk group of patients that we were studying. The limitations, of course, were retrospective design. Underpowered, we wanted more patients in both groups, but we were limited by how many patients were done with the suction dressing. To our knowledge, it was the largest cohort between negative pressure and other dressings in literature at that time. So we said the next step would be looking at the posterior approach total hip, and Dr. Tyagi and Dr. Gibson, my colleagues, went on and did that, and they published in the online journal here and found that particularly for the high-risk group, there actually may have been a benefit for primary arthroplasty to have the suction dressing applied in that patient population. So our protocol, since the study, we've really evolved away from suction dressings for primary hip cases. We do use the Aquacel dressing for all primary hip, knee, and shoulder arthroplasty as well as our spine cases. Our sterile dressing protocol, we do tend to leave them in place for 10 to 14 days or until the initial postoperative visit. Manufacturer importantly states that the indication is for a 7-day utilization for the Aquacel dressing, so that's important to note. And interestingly, since COVID-19 has hit, we've really eliminated the 2-week face-to-face visit for a wound check, and now actually arrange for home health care to check the patient, remove the dressing, and if there are staples, remove the staples. Then we have a video telemedicine visit. We've really launched telemedicine here at our center, and we connect with the patient to talk about pain control and therapy and guidelines from there. So a few slides about outpatient arthroplasty surgery at our institution. Yale New Haven Hospital is based in New Haven, and we have a center that we opened in 2018 that is a renovated area that has 6 outpatient ORs that are designed for musculoskeletal surgery. So everything from hand and foot and sports surgery, but also was built for total joints and spine cases in carefully selected cases to go there. So I led the efforts at that time in 2016 into 17 and right up to the opening in September of 18 to develop our outpatient protocol based on the available protocols and literature. And at 1 year, I figured that we'd have about 10% of my case volume. At the end of the year, it's about 20%. And at the 2-year mark, as we close in on that now, really it's about 1/3 to 40% of my cases are home same day, and probably about 2/3 are less than 23-hour stay overall for all comers. I'm there 2 days a month now. It's a hospital-based outpatient center for total joints. And I think that, total joint arthroplasty is really a high-performance field. It's a group of very high-demand patients, as you saw from Dr. Long's presentation earlier. They really are very well-educated folks that have high expectations. And I do think there's very little room for errors, complications, and infections. And I think the surgeon is obligated to do everything within their power to cut down on those risk factors and use tools that will help reduce the infection rate and improve the outcome in this high-performance setting. We had the pleasure of breaking ground. Of course, they gave me a mallet at the time we did the groundbreaking. I asked if I could keep it as a souvenir. They said no. It was really disappointing. But anyway, they built it, and they really did a nice job. And so this is our center and some of our techs for the first day that we were there doing a knee replacement. And we looked at our data just over the first year, and I ended up doing 61 total cases and about 4 other cases, about 65 cases out of my total case group that year. And really, we had good success. The ER visits were very minimal. There were two visits in 1 patient, believe it or not. There's no readmissions, no SSIs, no reoperations. And these trends have continued. I think there's been 1 other ER visit, but really no adverse complications or ill effects from the surgery or the outpatient setting. We had the chance to work with our anesthesia partners, Dr. Jinlei Lee. She's based at our center. She's the director of the nerve block study and protocol-based fellowship basis at our institution. Ed Mariano's out at Stanford. And we talked about with a standardized clinical pathway, outpatient joints can be safe and effective in a carefully selected subgroup of patients. Essential components really do have to include the selection, the preoperative education, the multimodal, multidisciplinary anesthesia, opioid-sparing techniques, and early and effective discharge planning. I think that a key thing for us has been the development of the nurse navigator program to help us not only select the patient, but optimize them right through the point of surgery and guide them thereafter. So my 3 take-home messages from this talk and the data that I presented. Number 1, our study's findings suggest that the SSI rate in the Prevena group did not differ from an Aquacel group, and such that the prophylactic use of the negative pressure wound therapy device we did not feel was indicated for standard or high-risk patients undergoing direct anterior total hip arthroplasty. Number 2, the savings was significant when using Aquacel instead of that suction dressing, finding that it was about $447 at our institution, which demonstrated the value of the Aquacel dressing in this study. And I do think the literature is starting to indicate that there very clearly is an evidence-based role to consider the closed incisional negative wound pressure therapy for total joint revision or periprosthetic fracture cases, which are high-risk cases and therefore have a higher complication rate for a variety of reasons, as Dr. Springer mentioned. So I think for those reasons, we'll consider it for the higher risk group, and we do use incisional therapy, vacuum therapy for those patients specifically. So thank you for your time. Thanks to our hosts at Becker's Healthcare and Convatec for sponsoring this evening seminar. And I'll turn it back to Brian as our host here. Thank you very much.
Great. Lee, thank you very much. That was an excellent talk. Many important points there, both about wound dressings and also about outpatient surgery. So I thought we might spend about 15 minutes or so in discussion. You guys raised so many excellent points during your talk, and we can obviously keep this casual and ask each other questions, but I wanted to start off just kind of with a general broader question. Will, you alluded to this a little bit at the end of your talk, and post-COVID, or just COVID aside, which is pretty hard to say, can Will, being in New York, which was the epicenter, and Lee, not too far away in New Haven, can you talk to me a little bit about what your patient's perception has been now about moving into an ASC setting? Has this really accelerated? And with both of you obviously also being at large academic institutions, is this a boon for the hospital system? I'm in a private practice, and I'll kind of share my experience with it. But Will, maybe if you could just initially just comment on what your volume and your shift has been maybe since the restart.
Yeah, I mean, I think this is an issue here. You know, people are concerned. They're concerned about going to the hospital. So perhaps we could talk about your overall approach to quelling some of those fears too. But the issue is they want limited contact. They want reinforcement and confidence. Despite being at a big academic institution, with 6,000 joints or something, remember, we're an isolated orthopedic only hospital at NYU. Now, I do operate at our other place out at St. Francis, but most patients are, in my experience, are interested. The New York area was very beset by going to rehab, actually, prior to all that. So
right.
It's got a high tradition of actually going for inpatient rehab. So the biggest thing that it's helped me with is a discussion of getting people away from rehab, which is a discussion I shouldn't have had to have over the last 5 or 10 years, but I have. But getting them to go home the same day has been easier. Our institution has shown a greater interest in partnering with this. So they have made it easier. And because we've done about 1,500, they've become much more willing to take away some of the difficulties, the barriers I felt we had to it. It can become very administrative. We hired 10 full-time employees when we instituted the protocol, and that can increase the paperwork and the institutional red tape. So they pulled away some of those barriers. The last thing that, of course, has followed this, and I'll end it with this, is the move towards shorter and shorter stay Medicare. Now, we were an early adopter of the BPCI bundle, and that has had a significant impact on our hospital's finances, is moving away from the inpatient Medicare designation. So I'd be interested in both of your opinions on that.
Yeah. Lee, I'm curious your comments. So you're seeing the similar shift? Is this patients approaching you about wanting to be done in an ASC, same day discharge, or is it less of you having to talk about it nowadays post-COVID?
Well, it's interesting. The comments are, coming from patients that they're seeking this out, as you say. I think we've reached a point, there's almost a tipping point in society that people are aware that you can go home after surgery. Mm-hmm. They want to go home and be in their home environment, and they want to stay away from a hospital environment where they could theoretically have more touches and exposures. So I think that there's a public acceptance of outpatient arthroplasty that didn't exist 3 or 4 years ago that has really changed how people perceive their ability to recover. And I think that is currently driving the discussions with the patients coming in saying, I'd really like to go home the same day. I never heard that question 5 years ago. I never heard it 3 years ago, but now I'm starting to hear it. So I think that as we normalize the outcomes and members of this group and elsewhere publishing on, the safety of this regimen to go home with the appropriate care, of course, I think the nursing care is becoming more accepted, and patients at home, when they consider this, they're not intimidated by it, and home healthcare agencies aren't intimidated by it. We've normalized it and proven that it can be done safely. So the science that goes behind it, the research, the publications that we've all been talking about, I think we're the first step in normalizing this kind of a practice and getting public acceptance that this is totally acceptable, it's totally safe, and for the right surgeon, the right patient mixed together and meshed together, then it's very safe practice. So I think that's helped. In the post-COVID era, when we went through our recovery process, the initial phase, we're really only doing urgent surgeries when we started getting access back to the ORs in the post-COVID phase. But when we went to phase 1 for orthopedics, we really had to select healthy patients, and the requirement was that they had to have a minimal hospital stay, and they had to basically get home with minimal resources in the hospital because we didn't have nursing floors and beds available right away. So we could do outpatient total joint. So outpatient joint surgery in my practice was the ticket for recovery after COVID. So I chose all the patients that I was going to book at the outpatient center, and I lined them up those first 6 weeks, and we did partial knees and healthy hips and healthy knees, and really patients that were up and on their feet and out the door either same day, or we allowed overnight stay just next day in a limited basis. So it was really an important part of that recovery. And I think that the patients appreciate the fact that we're ready to get them home. And we had developed the pain pathways, the nerve block pathways to do it so that they were comfortable and they can get up and go reliably every time. We were also able to take those pathways to a different hospital in our area because our main hospital was really overrun with COVID. The main hospital was really inundated. As you saw in New York, the same thing here in the main center in New Haven. So we moved about 10 miles down the road to a smaller hospital that had no COVID, and we started our patients there. So we brought our outpatient protocols, our nerve blocks, our injections, our pain control regimen afterwards, and we did the same thing there, and it worked. And it was a great way to recover for that phase one. Yeah. And then we ramped back into normal practice after that.
Yeah, and it just goes to show you, right? I mean, you spent so much time putting the protocols in place, getting buy-in from, you have to have buy-in from everybody on the team. If one person doesn't buy in, then the whole thing, falls apart. And, now you've shown that it's portable, right? You can take these protocols and you can move them from site to site. And, we followed the exact same protocols that you mentioned. We started our ramp up back with healthier, younger patients with minimal to no hospital stay, same day discharge. And Will, I did similar to like what you did when I first started to foray into this. Is I called every patient actually that night. Cause I was very conservative and very slow to send patients home the same day. I thought there was a huge benefit to keeping them in the hospital overnight. And really probably what it was our disorganization and just trying to get things, we need to have them stay overnight so we can get their prescriptions ready and we can get their PT organized and we can do this and that and, talk to them again in the morning on rounds the next morning. And fact of the matter is, if you have the program in place, none of those logistical type of executive functioning things are even necessary. Patients, and when I talk to patients, they much prefer to be at home sleeping in their own bed. And I think Lee, as you mentioned, the kind of the post-COVID, it's now acceptable. And now you have this tremendous amount of buy-in from the patients as well. So,
and that issue, getting patients prescriptions, was a big challenge initially. And then our hospital developed a little apothecary on site so that we could order the discharge meds and have them basically delivered right to the bed. And the patients didn't have to go to a pharmacy. It was ready for them when they were ready to go. It was handed to them. And that really helped streamline, everything we were doing. So that was a really big step for us.
So Lee, you mentioned this in your talk, and I think this is really important, and it kind of parlays into the bigger topic of telemedicine, which I think we've all been initially forced to do, but at least I know from my own experience, really embrace it now. But you mentioned initially seeing patients back in 2 weeks for a wound check and how you've eliminated that. I assume some of that is telemedicine. Some of that is the factors you have in place for, someone to go out and visit with the patient. But how can you talk a little bit about, with occlusive dressings and feeling now, probably realizing that you don't have to see these patients back at 2 weeks, and how are you implementing that into your practice?
Yeah, so telemedicine is tricky in orthopedics. It's hard to examine a joint and do a range of motion and really test it out. But one thing you could do really well is an incisional check. And so what we are able to do initially, we started with just a wound photo. We had them take the dressing off and just snap a photo and digitally send it to us through our nurse navigator, through one of the online electronic platforms that we use. And then we've moved into this 2-week visit where the home health agency will take the dressing off carefully. And if there's staples, they take the staples out. And we can actually look at the wound through a video consult on their iPhone or their computer or their iPad. And it really is one of those things that in all of telemedicine, it's one of the easiest things to do is look at a wound, because just as we're seeing each other tonight in real time, you can tell a lot from the video about what the incision is doing. And if there is concern, the first thing now we do is we're snapping photos, we're getting on a telemedicine visit, and we're checking it remotely. So it's actually one of the areas of telemedicine I think that was initially underappreciated. But wound checks and wound inspections and serial wound checks that we would often do in the office, that can be done very effectively in a remote manner with the patient's help at home.
Yeah, I agree. Will, anything along those same lines that you guys have changed or doing in what's your, kind of role relationship now with telemedicine?
Yeah, it's interesting. I'm personally, I feel that I'm already pretty busy, but B, I always feel that if a patient has a serious enough issue that I need to address it, I probably need to see them. So similar to Lee, I see everyone at 3 weeks still, but similar to Lee, my PA has been with me for 15 years. She's been at ISK for 17. She is, as you point out, and I think that sort of partnership, by the way, and you mentioned it, Brian, not be overstated. You know, the data is overwhelming that when you take a high volume surgeon and put them in a new environment, they become average. So to discount the other members of your team as being important to your success is setting you up for failure. So we do exactly that. We do wound checks via that electronic app that I showed. Can provide snapshots of the wound, can also show range of motion, so you can have short videos. We have a similar ability through Epic. So our EMR through the hospital actually allows that as well. And then we have a telemedicine system. These can be a little bit disjointed, but we have a telemedicine system through our office. It's also available through Epic. So we've sort of harnessed all of those. I'm a little bit leery about not seeing someone, particularly total knees and revisions at different time points. I think probably total hips, one could argue how many times you actually need to see them post-op. But I do think there are certain interventions you want to get on early with knees and a few things with x-rays, potentially with revisions. But I agree with Lee, and it might come back to what you said earlier, Brian, and that is just having the forethought to set it up and develop a practice that allows it to run smoothly.
Yeah. So I'll kind of take the other, maybe not extreme on that, but you know, I see all my uncomplicated primary hips and knees back at 4 weeks. That's their first visit back. They put they have the Occlusive Aquacel Dressing on for 2 weeks, and one of the things that's been helpful, and these are relatively new, but Convatec has created these videos of a couple different things. One is a video demonstration of actually how to remove the Aquacel dressing. You know, we had trained our therapist in doing it, but now we're sending a lot of our patients directly to outpatient physical therapy and not home therapy, and you know, no home health visits. So there are videos that are created that shows patients how, and family members, how to appropriately remove the Aquacel dressing. And then also a series of videos that show what normal dressing looks like, what spotting may look like, where it's okay to leave it on, similar to the pictures that you showed in your presentation, Lee. And then also what some dressings look like that are saturated or have leakage that say, hey, this needs to be taken off and the wound needs to be, you know, evaluated. And we've embraced the telemedicine as well. As Lee mentioned, it's perfect for wound checks and, you know, for wound evaluations. You know, so those have actually, you know, are proven to be really helpful for patients to be able to provide a link to them with the video to be able to, you know, learn to take the dressings off themselves and what to watch for. Lee, do you, at this point, your use of negative pressure wound therapy, maybe could you expand on that a little bit? And you know, you can talk, you know, inpatient, outpatient. What are your indications now for incisional negative pressure wound therapy?
That's a good question. I think that, you know, for simple primary hip or knee, I think we stick with the Aquacel. That's our go-to dressing. But
yeah,
for me, it's the patient with an unusual incision where the dressing may not sit well. And then you can contour a negative pressure dressing. Sometimes that's helpful. And I think that based on the data that we're seeing, that the sort of the truly high risk patient is not just the ASA3. That's not detailed enough. It's the nature of the procedure. It's the longer surgery. It's the more traction placed on the femur for periprosthetic management. As John Cooper is illustrating in some of his work, you know, I think that those patients for revisions and periprosthetics are the sort of the touch point for using this negative pressure therapy. And again, I would add the unusual incision or places where the incision, it's hard to put a dressing on. The negative pressure have better stick on those areas. So I think, you know, that's a nice role for it.
Can you mention just briefly, because you touched on in your talk, which is just the role of anticoagulation? You know, what's your standard go-to, and what are you seeing where sometimes you run into some troubles? Because I agree, it can really be the bane of a good surgery and a good wound.
Yeah, we have a standardized, like a normal protocol that we use for all hip and knee replacement, which has 4 criteria, and I think we have to keep evolving this protocol, but basically age over 70, history of DVT, patient who has active cancer, or someone who has a BMI over 35 has a high risk, and then we tend to use the factor 10A oral inhibitors versus everyone else gets aspirin 81 twice a day.
Okay.
I think smokers are sort of one of the areas that we would consider as a future high-risk group, and that's the surgeon's discretion. So those groups, we tend to use the higher risk anticoagulation, but certainly even at the prophylactic doses, some of these patients get into trouble. And I have a patient I'm thinking about with a revision knee who is leaking a little bit, is on a factor 10A inhibitor. So the first step in my protocol is to get them off of that drug if they're more than 2 weeks out and everything else is going fine clinically, wrap and compress the knee, and then reevaluate them in a few days or within a week in the office to make sure that there's no persistent drainage, because obviously that is a big risk factor. We did, I think it was a Pearl Diver study, or it might have been NISQIP. We're coming out with data that shows that if you reoperate on a patient's joint for hematoma, the risk of PGI is approximately 25 to 26 times. And that's in a national sample of major centers. And that data is really striking. I mean, you see odds ratios of 2 or 3, but operating on someone and getting a 25 times odds ratio for risk of infection after a hematoma of the joint that required a reoperation is a huge risk. So we need to be better about preventing these, hemarthroses and draining wounds.
Yeah, no, I agree. And
it's not a hematoma.
Yeah.
Yeah. So, Will, along those same lines, then, will you, your standard closure versus maybe a closure for a high-risk patient, anything that you do different, or do all wounds get the same closure?
Yeah, I mean, for all my primary hips, they get a monocryl, dermabond, and glue. My knees, I still use staples, and we did a meta-analysis on it, and then we did a randomized trial, and then all that other. I think you brought up a good point, and it's that the PA who works with me routinely is there for all the closures. But I would even go farther than that, and I think we've shown it in some videos that we've done over the years at ICJR. But knees can be an issue, and so can hips. I mean, I don't do any soft tissue dissection in the subdermal plane, be that in my knees or my hips. So I don't take the way I was trained, take the cob and scrape off the IT band in the hip before I split it. I just go straight down to the joint. And in the knee, I literally make a midline incision and flexion, the soft tissue's open, and I do a medial parapatellar arthrotomy. We looked at the ASA. We submitted it somewhere this year, looking at aspirin versus the toxic anticoagulants. Even in BMIs over 40, you're probably better off. We've got more and more data that will show looking at that. We're halfway through our randomized trial looking at the high risk versus low risk. So BMI over 35 wound vacs, and it's sort of showing the same thing, Lee, you mentioned, which is they are at higher risk in both cases, but it's still pretty small if you're attentive to the wound closure. The one last thing I'll say, Brian, is if you have a knee where you're really worried about it, nice tip Gil Scuderi, Norm Scott taught me years ago is rest the wound. And so they don't need to be doing deep flexion. They can still get up and mobilize. And you let that wound sort of coalesce as little as 48 hours. You can really decrease the tension on the wound and allow that partial pressure of oxygen to help heal the primary wound.
It's so true. We've gotten so good at our perioperative pain protocols and our aggressive physical therapy. Especially in knees, I wonder sometimes if we overdo it. Right, you go up and see the patient 2-3 hours after surgery, and they're like, "Look, I'm bending to 110, 15 degrees," and just like, "Oh, wait till tomorrow." Like that's, I think sometimes we tend to be our own worst enemies with how good we do with some of those things.
Yeah. I was going to say,
ahead,
for me, doing endoprosthetic work, I'll often rest them for 1 to 2 weeks because there's so much
Yeah.
dead space. So that's really the extreme case of a knee replacement with a distal femur replacement. But in that case, I do like to use wound rest. I let them get up and walk on it right away as a peg leg, but they have to be
Sure.
wrapped and compressed for 1 to 2 weeks minimum to avoid complications, because that's, you're talking limb threatening if you get to that point, and you really don't want to.
Absolutely. Yeah, it's a great point.
But interestingly, Lee, I'd like your view on this. I've got all the closed incisional wound backs for those, and initially this scared me, and but I don't put drains in. I have on some cases considered prolonged antibiotic coverage, but I don't put deep drains in. Are you doing deep drains?
No deep drains. Well, I've been using a combination of IV plus topical TXA for the better part of the last 8 years, and I've never looked back. It's been great. And so that really has eliminated my need for deep drains.
Yeah, same. I think we're better off without them now with TXA and things along those lines. So let me, one final question, and Will, I wrote this down when you were giving your talk because you mentioned it in your talk, and just to end on something with regards to outpatient surgery, you mentioned a little bit about expanding your indications and that you've maybe entered into a little bit of a shift. And I was wondering if you might expand on that. And then maybe, Lee, I'll just ask you to end with just talking about kind of your, patients that you're maybe still worried about same day surgery on. So Will, you want to comment on kind of your quote expanding indications?
Yeah, I think so. I think it comes down to the patient-related factors. So age, I'm less discriminatory about. So I'll do even some patients as old as 70. And the other thing that used to make me a lot more nervous was sort of body habitus. So I've found that if they're healthy and they're a little heavy, I can get away with it. It's, of course, a little easier with knees and hips. Hips can be a little more of a struggle.
Mm-hmm.
If you're just embarking, I have 2 assistants for my hips, and I think that, and my knees. So I find that very helpful if you're wondering about it. And I'm sorry that's a bit off topic for your question. And then the other thing is just the more technically difficult knees and hips that I look at, where I used to think, I feel more comfortable now as long as I template it and I'm using routine implants, a conversion from an old ligament reconstruction, a modified incision. Mm-hmm. So I've expanded it in those frames mostly.
Okay. And then Lee, maybe I'll slightly rephrase my question as we end here, which would just be your words of wisdom for people foraying into the outpatient, surgical world.
And I think that when you talk to patients in the office, I think that we all get a sense of who's a good patient based on their health literacy, their social support at home, their motivation, and how motivated they are to get up and go. And yes, I think that, the technical factors of the partial or total knee or the total hip play a role, but I think this is where surgeon's judgment comes into play. And I think that patient really has to want to be your partner in this process. And you'll know these patients when they come in. They're very active, very motivated people. I find that they tend to be very well educated, and they understand that they have to play a role in their healthcare and that they have to play a role in the recovery. And these patients are thrilled to do what we're doing, to go home the same day and be a part of this program and be a part of the opioid sparing regimen and have the nerve block and really buy into what we're doing in their own best interest. And I think that these patients are evident to us in the office. And I think we, as you were saying, Will, is that, 70% of patients may be candidates. I think if we look carefully and really ask the right questions of, who do you live with? What's your motivation to recover? You can find these patients that are ready and willing to be a participant, and they really have to be a participant in this event of care. And so that to me was the ticket to understand who those people were and then select the surgeries that were appropriate. We did not do revisions at our center. I have done a few outpatient, minor like bearing exchange type of revisions or arthrotomies or something like that. But for the most part, they're simple, straightforward cases and thinner patients by definition. But that patient has to play a big role in the recovery. And so learning to recognize that for me has been a big part of my development as a surgeon. And now I can see them in the office and I kind of pick them up as we go and you get a sense of who they are. I saw a guy this morning who was ready to go, and he's going to have it done in a week or two. So, you know, I think that's what I've learned a lot about. And again, I've learned about my partnership with my nurse navigator. We have a whole program now, and I have to give them a ton of credit because they work with that patient side by side as well, and they're on the phone with them, talking with them, educating them, and helping get them ready, get their family ready. And so all of this goes into it. But it's, I think, to me, the biggest factor is recognizing who that patient is. And every surgeon may define that a little bit differently. But once you see it and understand it, you start picking up on who those patients are in the office, and they're very willing and they're very ready to be a participant in their care.
Yeah, I think those are, go ahead, Will.
I was just going to say, and statistically, as I had time to think about it, Brian, the largest single group that I've moved more towards, and I was very reticent at first, is total knees. I mean,
Yeah.
I thought total knees was going to be a real struggle, and and the answer, unfortunately, is they still are. But they can struggle at home or they can struggle in the hospital. And they've told me repeatedly they prefer to do it at home. When they come, if you've done one in the surgery center and one in the hospital, they really do speak highly of the difference in experience.
Yeah, no, I think those are great, you know, great ending words of wisdom. We put so much science behind outpatient surgery, and the fact of the matter is there's still a little bit of an art that goes into it, and being able to pick those, you know, being able to pick those patients. So I'd like to thank Will Long from NYU and Lee Rubin from Yale for taking time to share your expertise and your wisdom around these topics. Gentlemen, you guys were wonderful. And, you know, thanks to Becker's Healthcare and in particular to Convatec for allowing us to get together and talk about these very important topics. So with that in mind, I'll go ahead and sign off. And any questions that come up from the webinar, I think I can speak for the rest of the faculty that we'd be happy to answer them at any time. Thank you very much, and everybody have a good evening.
Thanks, everybody.
Thanks, Brian. Great job.